Welcome, friends. It is our great pleasure to introduce you to SICOT Pioneer. Pioneer is a program of innovative orthopedic networking, e-learning, education, and research that was designed to fill the gap left by the absence of face-to-face meetings, courses, and other activities during the 2020 coronavirus pandemic. But Pioneer has become so much more than this in the intervening year. Pioneer is a virtual, but also very real community of like-minded orthopedists striving to help not only themselves, but one another. With the latest video conferencing and educational technology, as well as a groundbreaking online platform, SICOT's Pioneer events, activities, and resources are reaching every corner of the globe, with over 55,000 views of our webinars so far. We're forging new partnerships, signing agreements with 12 other international academic societies, and building an enduring network we hope will last for many years to come. So, what can you expect from us? Free webinars led by key opinion leaders from around the world and across all fields of orthopedic surgery and traumatology, as well as chat shows with some of the most interesting and inspiring surgeons on the planet. Opportunities to take an interactive role in these webinars by participating in polls and live discussions. Free on-demand Pioneer playback service. Watch our webinars again and again in your own time. And coming soon, our new bespoke learning management system will host podcasts, an online version of the famous SICOT diploma exam, virtual training modules, surgical technique courses, a discussion forum, and much, much more. We hope you'll join us on this pioneering journey as we push the boundaries of what is possible in online orthopedic education together.
Good day and a very happy new year, ladies and gentlemen. I'm Gowreeson Thevendran, consultant orthopedic surgeon from Singapore, chair of the SICOT Education Academy. It's an absolute pleasure to extend a very warm welcome and of course a very happy new year from all of us here to SICOT Pioneer Fan Club logging on watching us today from various corners of the world. It's truly an honor for us at SICOT Pioneer to host today's webinar, which is second in a series of webinars. Most of us are now accustomed to asking the relevant research questions and recognizing different sorts of studies out there. However, we often second guess ourselves when it comes to setting up a research project and managing it. To address that challenge, we are privileged today to have three prolific researchers who standing in the global research space really needs no further introduction. A personal note of thanks to our SICOT's Research Academy Chair, Professor Bhandari, and SICOT's Research Education Committee Chair, Ajay Malviya, for orchestrating the series of webinars and for moderating today's session. For the global audience following this live webcast, please post your comments and questions in the discussion box as we progress through today's event. And to our on-demand audience, thank you for following us. And we look forward to your enthusiastic support as we journey through this virtual educational stint in 2022. Ajay, over to you.
Thank you very much, Gao, and thanks everyone for joining us today. So as Gao has mentioned, this is the second of a series of webinars that the Research, Education and Mentorship Committee has planned. I hope you had joined us for the first webinar. So this one is going to concentrate on how to set up research projects and how to manage them on a day-to-day basis. And this is the team for today. Professor Mohit Bhandari from Canada perhaps doesn't need any introduction at all. He's one of the most esteemed researchers, well-renowned. He's the chair of our research academy. He's got more than 1,000 publications. He's got an extensive experience, and I'm sure we are all keen to learn from him and the experience of the other speakers who you can see. more importantly, I would like to thank my team. They've been working extremely hard, and over the last year and a half or so, we've obviously met several times, and we've decided that the best way forward for the research education roadmap of SICOT would be to have these series of webinars culminating in a big education day or at Kuala Lumpur. So Naritan from Albania, Tom Hilton from South Africa, Aju Bausko from India, Sasi from Oman, and Steve Chung from Hong Kong. Thank you very much. So I would hand over to Prof. Bhandari to introduce our first speaker, and he will also explain to all of you what the format of the day would be like. Thank you very much.
Great, thanks so much, Ajay. And as you can imagine, conceiving research or understanding the principles is vastly different from conducting research, especially research on a global level or research that involves tens of thousands of patients when you're thinking about these very large, databases and registries. So trying to understand that, I think, becomes critically important because they form the basis of so much, of our evidence base. Today, we have a format which we hope you will appreciate, which is going to be a hybrid of presentations as well as some, meaningful discussion following thereafter. We'll begin with our first speaker. Our first speaker today is going to be Professor Femi Ayeni, who is the professor and head of orthopedics in the Division of Orthopedic Surgery at McMaster University. He also holds a very prestigious Canada Research Chair that is given to a small fraction of surgeon scientists in Canada. I think less than 10 people hold that specific chair across Canada. So certainly a fairly impressive feat in and of itself. Dr. Ayeni will speak to us a little bit about how do we set up these multi-center consortiums and the issues around getting multiple sites engaged in research. We'll have lots to talk about after that as well. We will follow up with some discussion with, again, Professor Bauer, speaking about, the issue of registries and the complexities associated with that, as well as some of the actions that go with maintaining a high quality registry. Dr. Costa, we hope, will join us also very soon, and we'll be further talking about how do you set up and manage research, in the modern day environment. We'll obviously be talking a little bit about how COVID has affected that, but why don't we wait until the discussion period thereafter? So without further ado, it's my great pleasure, honor to present Dr. Femi Ayeni to give his first presentation. Dr. Ayeni.
Thank you very much for having me in this prestigious session with such great speakers, and to be introduced by somebody who I consider not only a friend, but a very dear mentor, Professor Bhandari. I've been really privileged to have learned from him over the years, and he's been a special contributor to my development over the past decade. As he mentioned, my talk really is about how to set up and manage projects using a concrete experience, which was the first trial conducted at McMaster University with our partners in Denmark and Finland. And it really isn't, about the content, but more about the journey and what you can anticipate when you're trying to conduct these studies. Next slide. For disclosures, that's my funding slide. Next slide. So impingement of the hip, we know, is a ball and socket issue. And for most patients, they understand it as a square peg and round hole. And it's really a condition where you have a misfit of the hip joint causing some early degenerative change and potentially osteoarthritis in some individuals. Next slide. And again, people tend to see it as something not fitting properly. It's more complex than that, but for now, it really is a condition where the hip joint is dysfunctional. Next slide. So over the years, when I started my career, we noticed that the operations to treat this condition was doubling every 3 years. And if you looked at data from the United States, you'd see the numbers of surgeries from graduates, and you can look at those bar graphs or line graphs. You saw this tremendous jump in all the operations being conducted. Next slide. As a result, we looked at where we were, and Dr. Bhandari was part of this publication, and you can see that bell curve distribution as to where we were in the adoption of arthroscopy. And we really were approaching a tipping point where it was being adopted, but the evidence was lagging behind. So we have a condition that seems to be important. We have a doubling of operations every several years, but then as it was getting adopted, there's a call to action to really try and define best evidence. Next slide. If you look at the evidence from 2005 to 2010, you'll see in this publication, next slide. And again, most of the publications were level 4, level 5 evidence, expert opinions, and a flat line across when it came to prospective randomized trials. So even in 2005 to 2010, there was a lack of information that was high level. And even later on, we saw this flat line and no progression in the level of evidence assessing the condition. Next slide. So we started looking at how to define the science behind this condition. And so we said, is there a need for a study? Can we do the trial? Who should be eligible? Which center should we involve? And what outcomes are relevant? And these are all parts of the preparatory work you should do as you're thinking about conducting a trial. Are you really looking at an important question or something that's been done many times over with no new ideas? And back then, with this new condition, a new understanding of how the hip develops and potentially gets into degenerative conditions, this was the right time to really pursue high-level quality evidence because none existed about how we treat this surgically. Next slide. So what was our rationale? The growth in procedures, the uncertainty based on our survey work, the lack of compelling randomized controlled trials, and a large number of systematic reviews we conducted looking at what are the indications for surgery, what are the outcomes we should look at, what are the patient important outcomes, how do we assess and diagnose a problem. So over the years, every systematic review was another building block to really define how we should conduct the study. And of course, there was a growing international consensus to work together to solve this problem of this lack and gap of evidence. Next slide. Next slide. That being said, as we're waiting for the next slide, I can continue to say that our strategy was then to really think about how to, push the science of impingement forward. And so the structure of our group was to really look and reach out to people, one who had systems that could help, conduct a study like this. So identifying your research partners is a key first move. Looking at individuals and centers who have a track record and demonstrate an interest in pursuing research is a key move. So when you're putting this together, certainly understanding and recognizing that it takes a team to accomplish these big feats and goals in doing studies is a big one, but recognizing that everybody plays an important role and selecting partners who definitely help you make that progression are key and important parts of the steps. I do have the talk on my end, so I can still discuss where we're now. We're now going to be on slide number 10, which is great. So our journey, as you see, is right there. It was literature reviews, international surveys, pilot studies, and then definitive study. And in every single step, we had publications to document and assess and get peer review of what we were doing. So for example, the sources and quality paper you see, that was to see if we had good information, which showed that we had a lack of high-level studies. The process survey was a survey of Canadian surgeons to see, should we do a randomized trial? The answer was overwhelmingly yes. And then our protocols, our analysis plan was published as well. So you don't really have to chase publications. The publications come to you when you're trying to answer an important question. Next slide. And and you can see the publications coming through, and you just keep clicking through. You'll see that over and over again, the publications that arose from our efforts were all publications that were supported by our drive to find out how to investigate this condition. Next slide. And if you stop right there, you'll see that all of these colleagues work together to try and put this together. But every one of those papers, the learning curve paper, for example, helped us define who should be in the study. Do they have enough experience to conduct a hip arthroscopy trial? The paper on patient-centered outcomes was what outcomes should we really track on patients? And so every single paper that's behind that picture really was all about defining who should be in the study. So the papers generally come as you're building a research program. Next slide. So we had our landmark trial looking at arthroscopic lavage versus bony correction or osteochondroplasty. Next slide. And a priori, we had published our analysis plan as mentioned. Next slide. And here are investigators, which I'm very grateful for. They remain lifelong friends. And when you do good research and you share data and you share recognition, everybody in the trial becomes a friend, which is really a great thing about research. Next slide. Again, Professor Bhandari was present as a co-chair of our steering committee. Next slide. Our oversight and data safety monitoring group, 3 esteemed colleagues again. Next slide. And our adjudication committee to see if the quality of the surgery was sufficient. So as you can see here, it takes quite the team to execute these studies and trials, a lot of volunteer efforts, and kudos and thanks to all my colleagues. Next slide. So you can see the progression of what we did. We had a planning phase, we had investigator meetings at multiple investigation sites and national meetings. And over time, we continued to build the rationale and to review the study and to ensure we had a safe and credible study until we finished it in 2019. Next slide. Publication in the American Journal of Sports Medicine, again, recognizing with group authorship the trial, and very well received globally. Next slide. So secondary studies, it wasn't just about, does the operation we do work for impingement, yes or no? There were many secondary studies which filled in the gaps as well. And so you have the publications that lead up to your study. You have the study itself that gets to be published. But then you have secondary questions from your well-collected data you can ask to fill in the gaps that patients and clinicians have after your initial primary study. Next slide. So here they are. We talked about adverse events. We talked about predictors of outcomes. We talked about trajectory of improvement, and on and on and on. And there's still more analyses to take place because we had a well-conducted trial with multiple partners, equal recognition, everybody pitching in. Next slide. So I thank you for having me speak today on this, but I just wanted to use that concept of what we did. And people sometimes look at publication numbers, but the reality is, if you're doing the work consistently across your time, you will definitely get papers that are impactful, influential, and not just the original paper you produced for the trial, but more importantly, secondary studies that inform new ideas, bring in new concepts. So thank you for your time today.
Many thanks, Femi. That was brilliant. So just shows you that one idea, how you actually pursue it, develop it, lead to the highest possible level of evidence, and how much effort it takes to take it through, and how much time it takes from 2013 to 2021, where your AJSM publication was. So what a long journey, isn't it? So, but just curious to know how many of such projects were you concentrating on, and how do you decide which one works and which one doesn't?
You know what, I think that was really informed by training and survey. So your patients will always tell you what to look at. So this was a focus of mine, and also, back then in 2009, 2010, starting out and getting the advice of Professor Bhandari was, well, listen, where is the biggest controversy and what is growing the fastest? And so whenever you seek controversy, it's not a bad thing. It's actually helpful because you can help define the science. And then when we were doing these operations, patients would ask, does this work? Or how long does it work for? Will it happen again? Does it come in? Instead of simply saying, we don't know, we don't know, we don't know, that was a call to action to say, well, let's actually define the evidence. So the patients will inform you because they'll ask questions. And likewise, when you go to the major meetings at SICOT, if you have, clinician debates, those debates are being held because there's no good answer. So I use those opportunities to really figure out where the controversies are.
Thank you very much. Mo, shall we carry on with the next presentation, or shall we just ask more questions of Femi?
No, I was hoping maybe we just continue on with Professor Bauer, and then we could just have just a long discussion until the end.
That's brilliant. So it's my pleasure to introduce Professor Henrik Bauer, who is a professor of orthopedic oncology at Karolinska Hospital in Sweden. He initiated the Scandinavian Sarcoma Group Registry in 1986. This registry now has more than 10,000 sarcoma patients entered from all around the Scandinavian countries. The registry forms the basis of several PhD theses that he has supervised. He's well supported by others, but clearly he has been one key opinion leader on this. He is actually right now working in Cape Town and helping develop the South African sarcoma registry with Tom Hilton, who is one of the members of our committee. So, Professor Bauer, would be keen to hear from you. You'll have to unmute yourself.
Thank you very much for this kind introduction and for this opportunity to try to share my experience of setting up a registry, running registries, and talking a little bit about what are they good for. We can have I have only one slide. We can have that one. The next one, please. There we go. So these are the talking points. And I think, why do we want a registry? Well, I think if you do something, if you produce something, for let's say cars, a good example, Volvo and Ford know exactly how long their cars last and why they break down. And there is in almost all production of things, you have to actually find out what happens when they break down, how do you take care of them? And I think the same is true if you do something as invasive as putting in a prosthesis in a person, you should also be able to tell that patient what are the risks. And it's not just a risk that you read about in the literature. You would like to say what are the risks in this specific setting where I'm working. The risks of having a hip fracture in Cape Town is probably not the same as if you have one in Stockholm, at least, and the fracture don't happen the same, at least in Cape Town, you don't fall on ice and break your hip. So you cannot just, I think, import data from other centers, which are also, and very much data is European or North American, and they do not always articulate or translate into the conditions where you are practicing your surgery. So I think that's why it is important to register what we are doing. And then we have to discuss, and I think that's famous presentation was very good, because is this research or is it quality control? Well, I think quality control is research. Sometimes people say, oh, you're just running a registry. That's not real research. I think that's completely wrong, because if you find out what you're doing and you're measuring it, you will also get better. So, which is actually what research is all about, improving things. And a registry will also be the basis for future research. As Femi so pointed out, there was one goal, and that was actually the randomized trial, but there were several more papers, and probably will be even more papers, where this data was used for secondary questions, which actually might be more interesting than the first question posed. So I think we do want to register. And then how do we go about making a registry? Well, the first thing is one which should think of, who can we copy? when there's no point in inventing the wheel. I just looked at the Department of Orthopedics at the Karolinska Hospital. We have 15 different quality registries. I think it will be quite difficult to find an orthopedics procedure that somebody hasn't already tried to make a register and account for what they're doing. So I think it's important to try to find collaborators. You can copy their registry. When we started the sarcoma registry in Scandinavia in 1986, we copied Anders Rydholm, Southern Swedish registry, which he had started 15 years earlier. And then, of course, with time, and I'll come to that, what we measure and what we think is important changes. What we've thought was very important in sarcoma registry in 1986 is in many ways less important now, and we have different outcomes. So my advice is go to meetings when we can go to meetings, discuss with people who present data from a registry which you find interesting, ask them, can I join? There's in my field, there's a fantastic example of this, and that is Richard Wedin in Stockholm, Jonathan Forsberg, who is, well, he moves around, but I think he's in Delaware now, in Maryland. He's in Maryland. And they started what they call a PathFX, which was actually getting prognostic data on patients operated for pathologic fractures. And once that got, Jonathan started it in the United States in his department. Then it was Richard did it, sort of verified the data on Swedish patients, and then they were verified on European patients. And now PathFX is lifted by data which is online, and where patients are entered from countries all over the world. So we don't only get European data, we get data from South Africa, we get data from Asia, we get data from South America. So if you can get a network of people who are actually interested in the same problem as you are, you can have a lot more, you can get patients, data much quicker, and you'll have much more fun when you go to meetings, because you'll have people you can discuss your project with. Now, the next question is, what can we measure and what should we measure? And that is really, you have to spend a lot of time on that, on which variables are measurable. Ideally, let's say, for example, it's easy data are the ones that you can get from the chart. For example, if you're interested in hip fracture, you can find the time the patient came to the hospital. That's hard data. That will be in any chart. You can see when the patient was operated. So you can get a quality parameter from the time, from how long the time spent from entering the hospital until the operation was done. Another quality parameter is when the patient is discharged. So these time parameters, if they are applicable, and I think they are in many circumstances, at least in tumors, definitely in trauma, and these are easy to find, and they are they're dependable. If you have another, if you try to assess infection, that becomes a lot more complicated. Is it deep or is it not? Is it, do you have to have a positive culture or not? But there's lots of good studies on this question. So you can actually rely on people who have spent time defining what is, for example, a post-operative infection. But And I think it's as far as you can try to find data that are in the charts. The Swedish hip registry, for example, there if you do a hip arthroplasty in Sweden, you can basically not leave the OR room unless you filled in the quality registry form. And that way it gets done. And so as far as what we can measure, I think that the main thing is try to find valid and important data points that you have when you start, which are meaningful over time. And then we come into the next thing, who registers. Is it the surgeon? Is it the nurse? Or is it the secretary? Surgeons are notably undependable. You can depend on nurses and you can depend on secretaries. Surgeons have too much other things on their agenda. So if you can make your registry that it can be filled out by a nurse or a secretary who will probably also stay there a lot longer, I think the long-term, the chances of running a long-term registry are much higher if you can find nurses and secretaries who do it. If you can also automatically in your patient charts transpose data into your registry. For example, simple thing like date of surgery, you shouldn't have to enter that. That should be, if you have computerized chart or digital chart, patient charts, that kind of data can run automatically into your registry, so it doesn't have to be entered by hand. And if you can do the registry as prospectively as possible, it will be much more valuable than if you have to go back and look at charts. The next really important thing is follow-up. Now, being a tumor surgeon, we have two follow-ups, or three. Did the cancer sarcoma recur? Did the patient get metastasis? And did they die of their tumor? That's quite easy endpoints. But if you're operating patients for hallux valgus, it's not so easy to define a simple and meaningful endpoint. I think in many studies, and it's also difficult to have follow-up. I mean, if you operate patients for an outpatient procedure, to get them coming back for a follow-up and examination, that is really very important. So I think many registries can be meaningful even if they do not have follow-up. If you have, for example, in hip fractures, if you have time to surgery, when they're discharged, if they come back for a reoperation, that's very good. Those are very good endpoints, even if you don't know how the patient is doing 5 years later. So when you build your registry, try to have relevant data sort of which you enter at the start of treatment and which are interesting per se and not dependent on the follow-up. Another thing regarding when you do follow-up is also, this has changed, but we all know that we are now trying to find assessments which are more based on what the patient feels is important than what the doctor feels is important. This came actually also from the tumor world from Toronto, where the physiotherapists and the surgeons there developed, I think it's called the TESS scale, where they actually asked the patient, what is important for you? And of course, the patients didn't say it's important that I can bend my elbow 90 degrees. They say it's important for me that I can bring the beer to my mouth. So they made these kind of patient based endpoints and not doctor-based endpoints. But that's really we know that. It's probably not, if you not really interesting to see, you know, this scoring of what is excellent and good. You can do almost anything to anybody, and 80% will feel that they have excellent and good outcome, and 20% will have a fair or poor outcome. That's true if you operate them for a sprained ankle, or if you do a amputation for a sarcoma. So you have to have better endpoints than that. How long do you follow the patients? That has to be decided beforehand. You have to, and I think Femi showed that very well. You really have to prepare your study before you start going too quickly. And am I talking too long, or is it okay? I'm just coming to the last point, which is the boring issues, but these have to be resolved before you start a quality registry. And that is, who owns the data? Is it the principal investigator? Is it the hospital? If you're many hospitals, who decides on what can be published? Who are the authors? Ethics is, of course, everybody knows about that, but you have to have think of the ethical considerations beforehand. If you do your study and then you find out, well, oh, I can use this material to answer some other questions. Well, do you have the ethics for that? So that is a very important thing. And also how the author list, and I think Femi also showed that very well. You can get not only published papers, but maybe even more important, talks at meetings where you tell about how your registry is progressing, what you want to study and why you want to study it, and how you're going about it. I think that's very important, especially to give that type of talks at meetings. And that way you also, more authors have a possibility to have papers and contribute to the studies. And there are problems, of course. Residents or registrars come in and they work for maybe a year entering patients into the registry, and then they go somewhere else. How do you make sure that they get some kind of recognition or authorship? And then finally, who pays for it all? You have to have think of the funding, so that you don't just acquire a lot of data, but then you don't have the means of analyzing it. Thank you very much. I think that's sort of the points that I think we can together discuss today.
Thanks a lot, Henrik. Yes, several things that we need to probably discuss, but I think we should hear from Professor Costa, who is around, and he is one of the shining lights of research coming from UK. He is the professor of orthopedic trauma at the University of Oxford. He's an honorary consultant at John Radcliffe Hospital, and again in Oxford. His research interest is in clinical and cost effectiveness of musculoskeletal trauma interventions. He's the lead investigator for several trials. You lose count actually. And then he's supported by, again, many grants from the UK National Institute of Health Research. The research that he's done informs lots of guidelines, nice guidances for especially. And he is the past president of the Orthopaedic Trauma Society, past president of the Global Fragility Fracture Network. So a well-positioned gentleman to be able to talk today. So thank you very much, Matt, for your time.
Thanks, Ajay. And yeah, I mean, a lot of the points I was going to talk about, I think Henrik and Femi have already alluded to, so I won't talk for too long. Just a few things to sort of emphasize, really, from the perspective of clinical trials, really, perhaps more than registries that Henrik talked about very clearly previously. And I put these into just 5 categories, which are available on the summary point slide. So I'll just run through those quickly. For most of the people on this webinar, this will be familiar ground, and I'm not telling you anything new, but these are just the very basics that are worth emphasizing, because without them, you really can't hold together a network. So the first one I suggested was about why multi-centre clinical trials are important. And frankly, if you don't get this message over, then people won't join you in the research. You've got to explain it clearly for people to actually want to engage with the projects thereafter. And the key reason is something called generalizability or external validity. So it's, can you take the information from research and apply it to your clinical practice? And a lot of research, particularly around orthopaedic trauma in the past, years ago, before Mo and so on, was single centre. And the problem with that was it was often expert surgeons operating on selected patients with interventions that were quite difficult to replicate outside. And translating those results, generalising those results to a whole healthcare system, never mind international healthcare systems, was impossible. And a lot of data came out later to show that what worked in the hands of an expert surgeon, often a design surgeon of a new intervention, a new operation, a new implant, didn't necessarily translate into benefit when it was rolled out more broadly across the whole healthcare system. So the key purpose really of multi-centre clinical research is to represent the whole of the healthcare system, or increasingly a whole of the international healthcare where that's possible around the world. And if you don't really explain that clearly to people, they won't engage with the project from the beginning, because they'll say, well, why don't we just do this in 1 or 2 centres? And the key reason is external validity or generalisability. The second thing, and I learned this the hard way, is about why, how you set up the network of recruiting centres. Now, if you get a load of orthopaedic trauma surgeons or any other professional group involved in musculoskeletal trauma in a room and ask them, do you think having a research network is a good idea? They'll all say yes, because why wouldn't they? The problem is, and this has been alluded to by Femi and Henrik before, when they go back to their day job, they get busy and they forget about their best intentions. And with the best will in the world, they're busy people. And why would they prioritise research? So what I found out the hard way was that research networks are built around a project. They're not built around an idea or an ideal. It's actually, you need something tangible for people to do, and do it immediately after you've had the meeting, so that people can get their teeth into it and make that a part of their day-to-day work. Because as soon as you leave it as an abstract concept, people forget and move on to the practicalities of operating in clinics and on-call work and so on. So actually build the network around the projects you developed, rather than trying to build it around a nominal framework or an ideal framework. The second thing is maintaining engagements throughout the course of the trial. Many of the biggest studies that people on this call will be very familiar with and have run often take months, if not years, to complete. And keeping people engaged, enthusiastic is a real art, actually. I think we now put more time into that than we do in the setup of the trial, or even the design of studies these days, about engaging people. And sometimes that's sort of mass engagement, having meetings of collaborators and investigators to report on progress with studies and so on, and we do that. Sometimes it's emails and phone calls to individuals who need a bit of help or a bit of support, or frankly, sometimes just be told you're doing a great job. Actually, a bit of positive feedback for people and make them feel part of the team and feel that their work has been appreciated. Because in the great majority of cases, the surgeons in particular, but many other members of the multidisciplinary team, are working for free. They're not paid to do the research. They're giving up their time for nothing. And so actually positive feedback is really important. People will work on altruism if they feel are appreciated. They don't necessarily need financial incentives. Something we do increasingly is WhatsApp groups, so small group messaging for investigators to share ideas, often even sharing x-rays in these sort of encrypted formats, so that people can judge eligibility and share experience of the trial or the particular study that we're involved in. I know other groups have used Twitter. I'm slightly nervous about that, because you often end up engaging conversations you don't necessarily want to have with people that don't necessarily have the same views about life, never mind the project, as yourself. So I'm not particularly, our group does a lot of social media, but I don't engage hugely myself. I'd rather do that in small groups of investigators. I think it's probably more productive, but I may be an outlier in that, and other groups use social media perhaps more effectively than I do. That recognition, that appreciation for people, I think goes back to something that Henrik certainly mentioned, Femi, as well, I think, about recognition for people. And that's really important. Not only important that people are recognised, but people are recognised for the right reasons as well. So these days we have charters that investigators sign up to, including associate investigators, trainees involved in study, as well as principal investigators leading the project in a particular centre, to say what you need to do to become a collaborating author on these papers. And actually, in some cases, have scoring systems, so recruiting so many patients, or doing such of this or that, or filling out paperwork, or checking adverse event reports, gives you so many points, and eventually the number of points will determine whether or not you tick the boxes for collaborating authorship. And that's really just to create an atmosphere of fairness, that everyone knows where the goalposts are up front, and everyone's clear about how they actually go about becoming a collaborating author. And then, as I've learned the hard way, if you miss someone off that collaborating author list, you will never hear the end of it. Actually, I've got a good friend of mine who is still speaking to me, but actually was deeply offended, and we just missed his name off the list. And no matter how many times I apologise and how many beers he's been bought, I won't be allowed to forget that. So it's really key to keep that list up to date, to make sure everyone's clear about who gets credit and who doesn't. And it's important for people in their careers, as well as just for the kudos of having your name on a publication, hopefully in one of the better read journals. And then finally, just a note about continuity. And again, everyone on this call knows about this. It's really important, if you want to keep a network going, sustainable network, is to have the next project lined up before you finish the last one. Because again, it's this problem of all orthopaedic surgeons are busy people, and they've got practical day-to-day jobs where they have tangible commitments to. It's not like academics sat around waiting for the next great idea to form in their head. They've got other work to do. So if you don't have a steady stream of projects, you lose that engagement, and rebuilding that then takes even more time and more effort. So we now have national meetings where we plan 2, 3, 4 years ahead for what projects we want to do, in what order and what timescales, so we can keep a production line. Ideally, making sure you don't have too many things on at once, but equally that you've got a steady flow of projects in the pipeline. So I'm going to stop talking there, Ajay, because I think people have heard enough from me on this subject, and other people have made several of the points, I think, albeit in slightly different ways. But they're just some of the summary points I thought were important when it comes to clinical trials and why, and establishing multi sort of centre networks for delivering those trials. Thank you.
Well, that's great. Thanks, Matt. Thank you very much for that. And certainly, Henrik and Femi, thank you all for taking time this morning. We have about 10 minutes. So if we could, I wouldn't mind asking you sort of, the broad questions. And I think we've all had this happen, where you'll have, investigators who are interested, those who will be listening or be watching thereafter. Sometimes some of them are very experienced and have done lots of this. Some of them are thinking, well, I'd like to participate in something large, or some of them are at the point of, coming right in and saying, how do I start? But oftentimes, I can't remember the number of times over the last probably 2 decades now, where someone will come and say, and their focus is so focused on how many patients do I need, how much money do I need, how do I allocate credit? And oftentimes, those don't turn out to be the things that really matter for getting a large group of people working together. And I wonder if each of you, and maybe I'll begin with you, Matt, since you ended off, then move from to Femi and Henrik, is where do you get ideas from? Because it's ultimately in the idea that leads to the specific question you're going to be asked. And I think if we think about where we are in the 21st century, I think the currency of this century is going to be ideas. And so where do we get good ideas from, and what's your process for each of them?
Yeah, I think the idea is everything, Mo. So I decided a good few years back that I was never going to have any ideas in my career. And that's because the ones that I did have, my colleagues told me, were either stupid or dangerous, or sometimes both. So the things I thought were important were not necessarily the most important things for anyone else. So I stepped back from actually having novel ideas myself and resigned myself to the fact we'll just implement other people's ideas. And that's been my way of life for the last few years. Where did ideas come from? It's the trauma meeting, ultimately. It's the things that we're discussing every single day on the shop floor. Are we going to do this? Are we going to do that? What's the best management for this patient with this injury? And, we all discuss it every single day. And it amazed me, and this is no news to you or anyone else on this call, how little evidence we had behind some of the decision-making that went on in those meetings. So that's where it all starts from. It's what are we talking about in the trauma meetings each day? We've now formalised that in the UK, and I know you've done the same thing in Canada and more broadly with research prioritisation exercises, so that we actually go and ask the community. And increasingly, we've moved to a system, certainly in the UK, of asking the patients what the priority is for them, which are often very, very different things. as I think Henrik alluded to earlier, the patient perspective and the surgeon perspective are not necessarily the same. So we now have quite formalized research prioritization processes where healthcare professionals from all the disciplines and the patients come together to set agendas for research. And then we just plug into which of those questions we want to answer in which order. The design of the trial and the specifics come after, but the general idea usually comes from this combined patient healthcare collaborative in prioritization.
Wonderful. Thanks, Matt. Femi?
Yeah, nothing, too dissimilar. I think it's a very, bright way to do it. I idea generate from patient questions. And anytime I say, I don't know, or, I have to get back to you on that, that's a light bulb going off. That's a problem that probably needs some investigation. So I use the I don't know test or we don't know test as a marker of something we can investigate. And then, like I said, previously to some of the trainees who would be on the call, is I used to like, and I still like going to the debates, the expert debates at any international meeting where you have two different camps debating a topic, because usually there is no good answer or they're half answers. So I like to sort of see what the thought leaders struggle with as far as decision making, and then use my I don't know test or we don't know test to drive what to look at and investigate.
Great, thanks. And I'll finish up with you, Henrik.
I actually probably go around it in sort of a different way, and I'll give you an example. I think my ideas for projects, they actually come from the data. And I'll give you an example. I started with sarcoma tumor research first, and then clinically late 80s, and then more clinically early 90s. And then I got very interested in pathological fractures and spinal metastasis. So I just decided, well, let's put all these patients that were operating at the Karolinska into registry. So that's fine. So then I did a lot of spinal metastasis then. And I said, well, we have to, so the next project then became, well, let's do some kind of a prognostic index or prognostication for these patients. So that became the next project. And then I think, well, now we know quite well what's happening to these patients that we operate, and we're better at selecting them. And then I looked in the literature. We don't know anything about 2/3 of the patients. We say either there's no point in operating them for the spinal metastasis, or they actually will do much better if we don't operate them. But we don't know anything about them. So then we decided to study the patients that we said no to surgery for some reasons. And how did they do? What were so actually the idea process can be very much data driven. And I think also Femi showed that in his randomized trial, that as they got the data collected, they also got more ideas.
Well, that's great, Henrik. Ajay, you had a question.
Yeah, I mean, it's probably not an uncommon problem that you might have faced in the beginning of your career, and many of the listeners, I'm sure, would be interested to know the answer to this. When I started, I mean, I'm talking about as a junior registrar, I went to one of my professors. I said, I want to do proper research. I want to do a higher degree. And then he said, why do you want to do it? I think you should just concentrate on clinical work. So the question is, how do you pitch yourself as a serious researcher? It's difficult to convince people, isn't it? So what do you have to say, Matt? Why did you start?
I think some people would question whether I'm a serious researcher or not, Ajay, so I'm maybe not the right person to answer. But I'd say I've changed my views about this over time and through sort of experience of being involved in trials and so on. So my view these days is that all clinicians actually are obliged, and I go as far as obliged, to be involved in clinical research. I don't think it's optional. I don't think it's fair for patients not to have opportunities to take part in research. So that's contentious, but I would say obligation to be involved. It's what does that obligation look like in practice? So the way that we run things in the UK, learning very much from what the Canadians did through COTS years ago and what was done in Scandinavia with the registries, was that everyone should be able to take part, but not everyone needs to fill out the paperwork. So in terms of writing the grant applications and processing the research ethics frameworks and all the things that Henrik alluded to in terms of just the nitty gritty, the boring stuff that needs to be done. Most clinicians don't need to do that and don't want to do that. So someone has to do that work, but all of them can be involved in recruiting patients into trials, talking to patients about options, which is what recruitment is, and then delivering interventions. The fact that patients have been randomized to those interventions is irrelevant. You're still doing the job delivering the intervention. So I think all surgeons can be involved in research. You then need a small group of people, and it's not many people are needed really, who are interested enough in the paperwork to do the boring stuff, and also have enough insight into methodology to communicate effectively with the statisticians and economists and trial teams thereafter. So if you're in that latter category, and people get the bug, that's how I got into it. I just got interested and then did more and more and so on. Then that's when a higher research degree comes in as a unit of currency in universities, essentially. But for most clinicians, you don't need a research degree to get involved in delivering research on the ground. You can be a vital part of that apparatus, that study, and recognized as such without having to do the paperwork and having to do the higher research degree and so on. So that's just my view. I'm not saying it's the right answer, but that's where I've got to now, that everyone should be involved, and a few people that want to, that show an enthusiasm for paperwork, can get more involved in managing the projects behind the scenes, but everyone can be recognized for being involved in research, every clinician across the board.
Thank you. Henrik, you wanted to say something, isn't it?
Oh, yeah, I forgot to unmute. Yes. No, I think if you're a junior resident and you want to get into a project, how do you approach it? I think you approach it by finding somebody who is working on a project who you like, who you can think you can spend time with. I don't think what he's doing isn't that important. The project that he's doing can be basically anything, as long as you think you can be with this person. And the really important thing is that you find somebody who actually writes papers. Don't start working for a professor who hasn't written a paper for the last 3 years, because he's not going to help you write one either. Don't start working with somebody who has this fantastic idea that you know will probably never be solved. Find somebody who actually gets the work done, so you learn the tools of research. Then when you have the tools, you can start your own projects. But keep it simple in the beginning. Find somebody who you can be with, and if they have the most boring project in the world, but they're writing 10 papers a year, just stay with it. It will be more interesting once you get into it.
Thank you. Femi, do you have any additional thoughts?
Yeah, no, absolutely. I think it's been well expressed. You know, to me, I would say just like exercise, just dedicate some time. I mean, if it's 30 minutes a day, that's plenty for research if you're starting out. And whether it's 30 minutes reading a textbook or a handbook on methods, or 30 minutes on participating in some form in a webinar, if you just take a week or part of your week and dedicate half an hour a week to start, eventually after that year, you'll be impressed by how much you accumulate knowledge-wise or talent-wise. So if you just make it a resolution, so to speak, to dedicate a small amount of time per week to a research experience or endeavor or skill, that is the first step in becoming more engaged, more involved.
Thank you.
How quickly this hour passes, as you can imagine. We are already at our hour. I want to thank all three of you, Professors Bauer, Costa, and Ayeni. Obviously, Ajay, thank you again for helping co-moderate this session with us, and Gao in his role in helping us through a very difficult time, generally around the world. So to have all of you, to see you is nice. I hope soon enough I'm able to, either be present in person, and I'm hoping that travel will once again presume that we get a chance to meet the old way, which was actually face-to-face. But thank you all, and once again, thank you, those of you in attendance, as we continue this journey on research. Have a good day, everybody.
Thank you, everyone. Thanks.
Bye. Thank you very much.
Bye.
Bye.
I think it went fine.
Yeah, see you. What did you think?